This is another chart review, case 2. Chief complaint here, I guess it's a status post shortness of breath. So the patient would be complaining of shortness of breath. History, 57-year-old male, medium body built, approximately 90 kilograms, ambulatory on scene with a steady gait, or he's taxiing. A&O times 3, answering all questions appropriately without no signs of respiratory distress. Patient speaking in full sentences in care of a first responder crew. Patient's skin is warm, dry, and pink. Patient expresses while on the airplane. This is at 11:45 our time here. An acute onset of shortness of breath while sitting down. Patient states he felt like he couldn't catch his breath, although, and a little typo there, breathing rate was normal. Patient related symptoms lasted for about 5 minutes and was administered some high flow oxygen by flight staff who activated EMS prior to landing at the airport. And he relates that the symptoms self-subsided and was refusing EMS treatment and transport. Patient denies any loss of consciousness, head, neck, or back pain, headache, nausea, vomiting, dizziness, blurred vision, tinnitus, auditory visual changes, sharp pinpoint chest pain, palpitations, unilateral weakness, abdominal pain, hip pain, numbness or tingling, GI changes, diarrhea, fever, cough, chills, recent illness, trauma, recent long bone fractures, recent surgeries, alcohol, illicit substance, drug use. Physical exam, skin's warm, dry, and pink. Head is symmetrical, normal, cephalic. Face, no facial droop. Surge speech, mucosa, moist and pink. Pupils of pearl at 3. Neck is soft, supple, non-tender. Trachea midline, no GVD. Back atraumatic, no obvious deformities. Non-tender to palpation. Chest equal rise and fall, no failed segments noted, non-tender to AP, and lateral stress, I think that would be. Lung sounds clear and equal bilaterally in all fields. Abdomen soft, no guarding, distension, non-tender to palpation, all quadrants. Extremities moves all well, strong equal pulses in all extremities, strong equal grasp. Strong equal plantar push-pull, all distal parameters intact. Ambulatory seen with steady gait, no lateralizing signs or arm drift noted. Treatment, they did say they put the vital signs somewhere on a sheet and extricated to the medic. It says lapse negative, placed on EKG, P performed 12 lead. No abnormalities, no S1, QT3, Q3T3. Adamantly refusing, multiple attempts unsuccessful. All right, and then the clinical impression here is rule out CVA, rule out ACS, and informed refusal. It did sound like this person in the chart, though, definitely tried to point out a little bit of hyperventilation, but didn't really touch on that. The carpal tunnel spasms, pleural tingling, or having an anxiety attack. No history of, or noted history of any type of anxiety disorder or behavioral or mental health issues. The patient, the chart, the writer here also, and the medic, or was also trying to paint that this could be a possible PE in their chart, but did not put it down in their clinical impression. Again, it probably would not be a PE, but we can tell that the person did put down like bones, surgeries, sedentary long flight, and then they mentioned this stuff about in the 12 lead here, long sounds being all that it is. All right, and then I don't know where the chief complaint of shortness of breath, they decided to do the CVA and ACS. If we were, then we would have to put down in our chart what's called pertinent negatives. So person, during this episode at no time did it sound like he had a headache. And here's a bunch of just pertinent negatives that just doesn't make any sense. It's just a stamp of things that we put down.